The neuroscience program here is just starting. We've been here about a year, but now we're starting to do some really complex things. Our group has been around for about 20 years. We were at Jefferson for a very long time. I used to be the division chief there. And most of us live in this community, and we're getting patients transferred to us all the time from here into the university setting to other hospitals. Crozier Hospital receives patients from here. So the hospital made an investment to have a real neuroscience program here. So everything from acute stroke intervention to brain tumors and vascular disease. And so I'll kind of go through some of this stuff quickly here, but this is a slide showing this community, and that the majority of these people who live in this community go outside for their health care for neurosciences. And when you're dealing with acute things, acute stroke, brain tumors, seizures, things like that, that shouldn't be, especially at a hospital system like this. So, Comprehensive Center does all types of spine, including spinal cord injuries, trauma, brain tumors, vascular, including stroke, intracranial stenosis, bleeds in the brain, functional neurosurgery, which I'm going to show you a little video of a patient undergoing awake brain surgery, which is very cool. Peripheral nerve surgery, carotid disease, the whole lineup, if it has to do with the neural system. So we're not one or two private practice doctors. We're all affiliated with Drexel University College of Medicine. And you can see this is our team. And everyone here is a subspecialist treating specialty, whether it's Parkinson's, cognitive disease like Alzheimer's disease, stroke, brain tumors, all types of rare neurologic diseases too. And then we have subspecialty as well. We started the country's only neuropharmacy program. So everyone's been to a doctor, and usually the medicine's the biggest problem. Doctors don't even know anymore what they're prescribing. One doctor's putting a patient on something, the other doctor's putting them on something, and there's an interaction between the meds, but they don't communicate. So we kind of said, look, this is stupid. As doctors, we're going to admit that we can't even keep up with all the new medications. So we have a neuropharmacist who goes through and meets with patients, sees patients with us, it's the same visit, goes through the meds, will call their doctor and say, look, I'm going to recommend this is what we should switch. And they talk to the patients and answer their questions. This is our main center, which is up about 15 minutes from here in Pennington. It's a 40,000 square foot. If you walk in, this is what it looks like. It doesn't look like a doctor's office because it shouldn't. You got enough stress if you're sick and you have, health issues. You should walk in somewhere that kind of calms you, open space. It should look like a hotel lobby. And that's what we went to great lengths to design. Quality. Oh, I thought you had a question. Okay. So our quality. This is an independent quality metric company called Premier. So they, without any, on their own, they collect data on quality of groups. Our quality, our outcomes, complication rate, patient satisfaction, all those things bundled together, we're better than Abington, Banner, Einstein, Geisinger, George Washington University, St. Luke's, and yes, Thomas Jefferson. This isn't our data, this is independent. So, it shows you that this model works. Aneurysms are something that we treat a lot of. This is the old-fashioned way to do it, which unfortunately still has to be done, where we open up someone's head and we go in and we put a clip and treat the aneurysm. And most times these are ruptured because most people don't know they have aneurysms until they get a bad headache and it's too late. So this is a traditional approach. That's a brain. That's us doing open brain surgery. But this is the future now. We can treat we can do brain surgery from someone's wrist. Just like literally we can go through the artery in the wrist, an artery that's that big. And this is our new operating room. So the operating room is not what an operating room looked like even 10 years ago, let alone 20 years ago when I started. It's this hybrid operating room suite where we can put a catheter in here, look at all the blood vessels and brain. If we need to open the head, we push a button, all that equipment goes out, we can open the head. That's what St. Mary's is building right now. Hybrid operating room, yep. And this is the way we do it. This is an aneurysm right here, and this is a microcatheter. Again, this is all going through the wrist, and we plug the aneurysm from inside. As opposed to going outside and clipping it, we plug it from the inside through the artery. And then these are some of the newer techniques now where there's stent flow diverters. It's a brand new technique. We actually helped design this back when we were at Jefferson. We just did the first one this week here at St. Mary's. Before this, these patients would have had to go on into the city. This is a arthroscopic knee surgery. So you may be wondering, why am I showing you as a brain surgeon or arthroscopic? Well, we started looking at things like this with some of our colleagues and saying, if we do this in the knee, why aren't we doing this in the brain? If we're going into these minimally invasive for someone's knee, why are we cracking someone's head open and taking all this bone out? So this is a big hemorrhage, is a CAT scan. This is a large hemorrhage, and traditionally we remove half the skull, go into the brain, take it out. So this is a device that actually we helped design and is now being used around the country, where what we can do is, if we go back, this handheld device, through an opening about the size of a dime with like a GPS system, we can go right in and the screen will tell us where that clot is, and we just suck it out. It's like a suction irrigation, and then pull it out. It's much less invasive, very cool technology. Brain tumors, I don't know if you guys remember this, a while ago, a 29-year-old girl was diagnosed with a high-grade glioma. It has a life expectancy of about 6 months, horrible. 50 years, so think about 50 years ago, healthcare, the outcomes if you had that diagnosis 50 years ago to today, it's the same. That's how, and everyone talks about gene therapy, it's the same. It's a horrible, horrible disease. So we work with some of our colleagues at Cornell in New York. This is a tiny little microcatheter. This is a brain tumor, but it's all the arteries feeding the brain tumor. So how do we give chemotherapy? We give it through the arm, right? We give chemotherapy through a vein, the whole body absorbs it, your hair falls out, you're sick, you become immunocompromised, and about 10% of it gets to the brain. So working with some of our colleagues, we're like, well, wait, we can do all this stuff through the wrist and the blood vessels. Why don't we deliver the chemotherapy right to the brain tumor and douse that tumor directly? Less side effects. So this is something that we're going to start doing. We've been doing this for about 8 years now. We're going to be doing this at St. Mary's very soon. That's a brain tumor on a young man who started off having headaches. You can see that big ring here. And our treatment is removing it. You cut it out, remove it, get chemotherapy, radiation, tumor's going to come back every day of the week. Take it out when it grows back, and until there's nothing left to do. So this is a first patient that we did this on. This was his tumor after being resected. You can see it. There's a site where it went in. And after giving that medication directly and dousing it, you see the brain tumor literally dissolve. Now, did we cure it? No. But this person had an extra 3 years to live as opposed to 6 months, didn't undergo all these horrible side effects of chemotherapy. So now what we're looking at, we know this is the right delivery, but we need to find a better drug. And that's really where the problem is nationally. And if you go, this is something too that's this patient came to us from HUP. A lot of our patients come, we just treat someone from Cleveland Clinic. So why are they coming for this? What that tells you, anywhere you go, if you have this brain tumor, Johns Hopkins, Cleveland Clinic, Stanford, you name it, you're gonna get the same treatment. There's one protocol, one standard of care, and we know it doesn't work. So again, it's trying to think outside the box. That's the patient and his wife. And again, he did very well for 3 years, and then he succumbed to the tumor ultimately. But this is something I want you to see. This is a very cool case. What's that? Yep, yeah, because well, you can, but then the cells get smarter, and that's why we need a better drug. But this is something this is very remarkable. So Parkinson's disease, right? One of the debilitating effects. See, this is a patient with Parkinson's disease, his arm's shaking. He's awake in the operating room. His brain is open behind that curtain, and what we're doing is we have electrodes that are going into the area, the pathway of the brain that controls this tremor. And what we can do, and this is Dr. Sarkar, who's our chief of functional neurosurgery. So you can see this poor gentleman, he can't drink a cup of coffee. He can't call his daughter, he can't call his wife on a cell phone. He's trying to write his name on the left side. So there's a electrode in his brain. Behind the curtain, we're increasing the stimulation of that electrode to override the pathways to the brain that cause the tremor. Watch what happens. As we start to slowly increase that and send a stimulus, it goes away. Literally goes away. And why we're doing this awake is we need to see where that level is. And once we see the sweet spot of like, okay, this is exactly the level that interrupts the tremor, we do it permanently. So this is, now we're going to come off. Now we're turning it back off. Watch what happens. And again, keep in mind, he's awake and his brain is exposed with electrodes in it. So as soon as you turn it off, it comes back. Then you're going to turn it back up and you're going to see it go away again. And so that kind of, now we know that's where it is. We lock that frequency in. We internalize those electrodes and there's a little battery pack. So that will interrupt his Parkinson's. He's calling his wife. You can't hear it, but he says, that's the sweet spot, baby. So, you know, these are life-changing procedures. These are things that really make a difference. We're going to be doing this probably about 3 months here at St. Mary's. Yeah. So for people, now they have to be screened. Not every patient's appropriate for this, but you can see, you know, the advancements. And a place like St. Mary's, this is where you should be doing these types of cases. You don't have to go to the city. And imagine not having to go into the chaos of a large academic university center, excuse me, and be here in your own community hospital and drive 5 miles away, 10 miles away, not have to deal with that extra stress. And these, again, these doctors, these surgeons, the team, these are all leaders in the field. These aren't just community doctors who are kind of, you know, they're not reading the books, they're writing the books. So anyway, so that's a new program. I'm happy to answer any questions if anybody has any.
Recognizing symptoms of a brain tumor.
Uh-huh.
Are there, before it becomes, I had a friend that had a brain tumor, but by the time they recognize those.
And that's a problem. It's usually headaches. It's not infrequent to have a seizure. You know, people have never had a seizure in their life, then they have a seizure. When I hear that, especially in a child or a young person, really anyone that doesn't have that history, the first thing you're thinking about is a brain tumor. And then to your point, depends what kind of tumor. Some of them are benign, and they grow very slowly, but they get so big they start causing symptoms. But the tumor that I showed you before, that has it's a horrible. It's the worst type of cancer of any cancer you can have. That and pancreatic cancer. I mean, life expectancy 6 months, and glioblastoma multiforme, or GBM. You know, John McCain died of it. Senator Kennedy died of it. You know, there's a host of people, and I was showing the. I don't know if you all remember, but this was the front page of People magazine. This 29-year-old, it was very controversial, and she, you know, this was. I'm trying to look at the year. I mean, it wasn't that long ago, but I was saying 50 years. From 50 years ago to today, we've made no advances. We really haven't. I mean, we're extending life, but it's not a great life. I mean, the life expectancy is still the same, which tells us we have to do something different. So, but, you know, the good news is we're bringing this all here to St. Mary's. St. Mary's is investing in new programs that are, you know, the most important, not that any others aren't, right now is neurosciences. Because if you think about what covers neurosciences, Parkinson's, stroke, Alzheimer's disease, concussion, brain tumors, neurotrauma, spine, back pain, spinal cord injury. It's a huge catchment. As we all, myself included, are getting older, these are becoming more and more, you know, relevant things. And you can't just do this as kind of a community. You know, you have to have a system where everybody works together. Neurologists, neurosurgeons, pharmacists, everybody's on the same team.
Short-term, when you get older, short-term memory seems to be the
yeah, and that's one of the most common things we get in the office. I mean, after the age, and everyone's a little bit different, but certainly by 50, our memory starts to do this, particularly the short term.
Now, why is that with the short term and that doesn't affect?
It's just where the brain starts to kind of shrink and atrophy. That's kind of, you know, it starts that way.
Are you working on putting like a memory stick in?
No, but I mean, that's going to be pharmacology. We're really looking at, and you see how many misses we've had with Alzheimer's, right? Everything from microwaves to aluminum pots, and, you know, what that means is we don't know. And one of the biggest trials was a failure. Because I think, in my humble opinion, I think we're looking at the wrong thing. Everyone's focusing, they think they know what causes it, but when you try all these medications that interrupt what you think is the cause and are not working, that means you got to go back to square one and say, okay, we're missing something here.
Available now to prevent it. Like if someone's younger now, they have it.
I mean, there really isn't. No. There's things. There are some medicines like Aricept and things that will help short term, with some of the side effects of but it's again, it's short term. But again, until we know what causes it, we don't know how to fix it.
They did a lot on diet.
Yeah, they looked at diet, and there's still a lot, you know, and then the stuff, cigarette smoking, alcohol. Well, okay, well, that's bad for everything, but it's not a cause of Alzheimer's. You know, there's really, it's more, they're starting to look at like activity. They're, you know, people that are less active, less social, live by themselves, they're more at risk. And that kind of makes sense with memory and, you know, higher functioning of the brain. But Alzheimer's is a disease. Anyone that tells you they know what it is lying. But we're getting there. We're definitely making, you know, strides, but we got to do a better job. So, and that's what we're trying to do, is push the envelope. But anyway, all right, well, thanks, guys.